Welcome to our third annual Pediatric Week's lecture series. Our theme for the week is Not All Heroes Wear Capes, Some Wear Stethoscopes. And so we've had an exciting week so far. And as we continue to progress, we are proud to have our Pediatric lecture series presenting today. We have four distinguished lecturers that will be a part of this series, and we are getting ready to start. So just to introduce our first speaker, her name is Shanika McIntosh Cooper, and she holds a Bachelor of Science in Human Occupation with a minor in psychology from the Louisville University, Buffalo, New York. She also completed a Master's of Science in Occupational Therapy from the same university in 2011. Mrs. McIntosh Cooper has had extensive experience in inpatient and outpatient rehabilitation, school-based therapy, and pediatric rehabilitation, having worked in both the United States and the Bahamas. She has great knowledge and expertise working with neurodevelopment and neurological disorders in children. In 2016, Mrs. McIntosh Cooper established the Occupational Therapy Consulting Services, a consulting firm that assesses and provides intervention and support for children with neurological disorders, learning, development, and intellectual disabilities in Nassau, Bahamas. She also provides training and consultancy services to medical professionals, teachers, and civic groups, including starting the provision of consulting, training, and assessment services for children on the island of Abaco. Mrs. McIntosh Cooper is the co-founder of the Occupational Therapy Association of the Bahamas, president of the Association of Caribbean Occupational Therapists. She's the former Bahamian delegate for the World IF Federation for Occupational Therapy, and also a former coach for the Bahamas Special Olympic track and field team. So we are more than delighted to have Mrs. McIntosh speak to us on her exciting topic. It's something we as pediatricians and parents alike are always concerned. And she will be presenting on understanding food aversions in toddlers. We ask that all questions are held until the end. And if you have a question, please feel free to put your question in the chat. So without further ado, Ms. McIntosh, the floor is all yours.
Good morning, everyone. Once again, my name is Shanika McIntosh Cooper, and I am a pediatric occupational therapist. And today we'll be discussing food aversions in toddlers. So what are they? What are some of the causes? And what are some practical strategies for managing them? So food aversions in toddlers can be frustrating for caregivers and may have developmental impact on the child. So by understanding the root causes and implementing evidence-based strategies, we can help children build healthier relationships with food. So what is food aversion? Food aversion is a strong dislike or refusal to eat certain foods due to sensory sensitivities, past negative experiences, or medical conditions. So unlike picky eating, which is usually temporary, food aversions may be more persistent and can affect nutritional intake. So some common aversions would include, specific textures, colors, temperatures, or even strong flavors. So picky eating refers to a temporary phase where toddlers reject certain foods, but are generally open to retrying them later. So you would have parents come in and say, well, they used to eat spaghetti before. Some days I could get them to eat spaghetti. Other days he'll pick at it, he wouldn't eat it. Then we'll have to try different foods. So they're eating, but they have their preference and they may reject that food at that particular time. Unlike food aversions, picky eating is often due to preferences, whatever they prefer, what type of food they prefer. And it also depends on what mood that child may be in that day, rather than a sensory or a medical issue. So food aversions, on the other hand, can persist and may require intervention to prevent nutritional deficiencies. Our picky eaters are still eating the variety of foods when they want to eat it. So they're getting some of those nutritional value, where our food, those who have food aversions may not be eating enough, or may not be eating the foods that they need in order to gain those nutritional values. So what are some of the causes of food aversion? One of the main causes would be the sensory sensitivity. So as a pediatric occupational therapist, one of the most common causes I see for food aversion is really sensory sensitivities. So sensitivities to texture and flavors of food. So when a child has sensory food aversion, they will often gag or even vomit at the sight, the touch, the smell, or the taste of new foods. And that's because their brain is overprocessing the sensations, which means that the child is intensely and negatively experiencing the smell and the texture and the flavor. And those sensory food aversions, most kids that have them will only eat certain types of food, like crunchy foods or sweet foods. So they would eat, but only food perhaps within a particular texture that they feel comfortable eating, that their brain is able to process as maybe a safe food. Their taste aversions may cause them to refuse anything that may be sour, bitter, or even savory. And texture aversions may cause them to avoid mixed foods like casseroles. Some kids prefer puree food. Other kids do not like puree food. Another cause of food aversion would be more learned behaviors. So if caregivers or parents react strongly to a child's food rejection, or frequently accommodate avoidant eating patterns, the aversions become reinforced. For example, a few weeks ago, I had a parent contact me, and she admitted, she's like, you know what, I know my 3-year-old is having difficulty eating a variety of foods. He's only eating puree food because I know it's my fault. So she tried giving him, I think it was rice or something like that, and he had a gag reflex, and she panicked. And she, took the food out of his mouth, and she started to panic, and the kid started to panic. So the child was feeding off of the mummy. So now she is unable to get him to eat anything where he has to chew, or anything that feels a little bit firm in his mouth. Now he's avoiding all of those types of food. So now she has to put the rice, put the chicken in a blender, blend it up to a softer texture, where he's able now to just kind of squish it in his mouth and swallow it. So he is learning based off of mom's reaction to when he first initially, when he's first initially started to eat those firm textures. And we're seeing a lot of that as well, especially with new parents. We have to kind of guide them through, it's okay, it's a different texture. Just try to teach them how to clear their throat. Do not panic. Make sure you're giving them small amounts so they're able to chew and deal with the flavor of the smaller amounts before you pack their mouths with food. How you respond is how they're going to react off of it. So definitely learned behavior is one of those things that we see influence some of the food aversions. And how you mitigate those would be more positive modeling of behaviors, maintaining consistent meal times, expectations, and just being able to not respond in a panic or fearful or an anxious way. Psychological. So sometimes we've seen cases when a child would have been ill and they vomited the food that they ate. So a negative association is made between the physical discomfort and the food. So likewise, you have children that experience maybe surgical procedures that affect their throat and mouth. So whether they've had feeding tubes, they've been intubated, they can also develop the food aversions in general, because they have negative association with anything near their mouth or their throat, and they want to avoid any discomfort which causes them to refuse many or even all foods at first. So as time passes, this begins to affect the sensory system as well as the oral motor system. Because if we're not putting anything in our mouth, then all of our oral motor muscles, our jaw muscles, our tongue, lateral movements, they're starting to become very weak because we're not using it. So you have an increase in a pretty much increase in sensitivity now because you're not used to having anything in your mouth. The mouth is not being stimulated. The jaw movements are not being stimulated. And so there's now an additional component of sensory food awareness, food aversion in these types of cases. You also have medical conditions. So this is also true for eating and swallowing that's very painful. So those medical conditions like GERD, some allergies, lots of gastrointestinal difficulties, maybe some constipation where, you know, eating may be difficult. Maybe a stomach is not emptying out the way it's supposed to. Maybe there's some reflux that's causing some pain or discomfort. And now you are avoiding food because you're now associating the food with the discomfort, or because of the medical conditions, you don't want to eat. So you have that as well. Two of the biggest culprits are gastrointestinal issues and constipation, and also kids that have had medical testing. As I said earlier, some of the feeding tubes or severe vomiting, any physical incident around their mouth or their throat, even from infancy with parents forcing food, forcing bottles, forcing spoons down a child's mouth may have the child may be scared of anything coming towards their mouth and be overly sensitive in that area. Now, on the other end of the sensory spectrum, a child may not be able to even discriminate food in their mouth well. So you'll have some kids that may eat, but they're gonna stuff their mouth because almost like a chipmunk, and you have some kids that pocket as well, because it gives them some type of feedback to where the food actually is. So you'll have some kids that would avoid the food, and then you'll have some kids that they'll only eat certain foods, but they will pack that certain foods that usually have textures. They will pack their mouth with that food so that they can have some type of sensory feedback that there's actually food in there. Usually you see that a lot when you have those muscles that are weak in the mouth, as well as those kids that may be desensitized to only eating certain types of food. And then there are also developmental disorders. So I'm also a certified autism specialist. And a lot of the kids that I see with food aversion are kids that are on the spectrum. And a lot of it plays with sensory sensitivities. A lot of them already have sensory processing disorders, and they have more difficulty. I see a lot more of them than anything else, where they have difficulties with eating a variety of food. And then, of course, you know, we have issues with malnutrition and weight loss and not growing the way they need to be growing. So some medical conditions, these are just a few that may affect the way the child eats or refuses food. You have the gastroesophageal reflux disease, which can cause pain and discomfort. And as I said earlier, if a child is in pain or there's feeling some discomfort, the tummy feels full, the stomach is not emptying the way it's supposed to, they're not going to eat. They're going to avoid most foods, or maybe just have liquids or have foods that are pureed where they feel it's not going to cause them any pain or discomfort. You have the avoidance restrictive food intake disorder. So it's an eating disorder where there may be restrictive eating due to sensitivities, fear, or kids may not eat at all. And they don't take food. It all depends on what type of food, but a lot of those kids with this particular disorder prefer not to eat. They would drink. You have to do a lot of pureeing, you have to do a lot of smoothies, but they do not do not eat due to sensitivities or past experiences where there is fear. And then you have a lot of food allergies as well. And we're noticing an uptick in the food allergies with kids with specific food. Milk is a common one, but we're having other allergies that are coming up. So kids are because of the experience they may have with an allergic reaction, they would prefer not to eat at all and not to eat specific food. And as I said earlier, one of the more of the neurodevelopmental issues is with kids that are on the spectrum who have a lot of sensory processing difficulties in regards to eating. So what are some of the signs and the symptoms that we're looking at? We're looking at when you have parents who are coming in and they're like, listen, my child isn't eating anything, or he's only eating pureed food, or when I present to him the macaroni or present to him the Kraft dinner or whatever it is, there's a gagging and a vomiting. So the food may not even be in the child's mouth. The child may just see the food or know mom is in the kitchen and he has the mixing of the bowls and whatnot. He's already starting to gag and to vomit. There's almost a distress. And you have some kids that have a whole tantrums before they even get the food in front of them. You would have them crying, throwing themselves on the floor because they know that it's feeding time. They've had a negative experience with feeding. This is something that they want to avoid as much as they possibly can. Other things would be kids having a very limited variety in diet. And you would hear this a lot too. Mainly kids that they don't accept more than 20 types of food. And they tend to eat the same type of textured food. I had a kid recently, we were trying to work on vegetables. And we tried he would only eat like beige or white food. Anything with color, he would reject. So we did a play therapy with the broccoli being little trees. We had little carrots. We had a number of different stuff, and we just made it in a playful way where he had to create a scene. And he was like, no, I'm not eating this tree. It's a green tree. I want a white tree. So we had to get cauliflower, and believe it or not, he did try. He made an attempt to bite the cauliflower. So he only ate based on the color. Of course, he was on the spectrum, but he only ate the white or beige or light colored foods. And then there would be physical symptoms. So kids that are not meeting their weight goals, they're losing weight, they're not doing very well on their growth chart, and they're obviously, some vitamin deficiencies and a number of other deficiencies. So we know they're not eating of the variety of food that they need to. So a study was done in 2021, and there's been an obvious increase in reported food aversions over the past decade. Now, there could be a number of different reasons, in which we're going to discuss quite shortly, why there is an increase in food aversion. Sensory processing issues. So a lot of kids are now having heightened sensitivity to texture and tastes and smell of food. And that could be also associated with the increase in prevalence with kids being diagnosed with sensory processing disorders, with kids being diagnosed with autism spectrum disorders, with kids not having the opportunity to have exposure to a variety of food at a younger age. Sometimes our parents just tend to do puree and baby food, and the children have teeth or they have gums that they could try and chew other foods. We tend to play it safe. So when it's time really to start chewing and being exposed to those other foods, there's a heightened sensitivity. There's also a rise in gastrointestinal disorders, where there's a lot of reflux and some food allergies that are making it uncomfortable, so children are avoiding. And we're going back to parental feeding practices. A lot of our parents, and I could understand it, I want my child to eat. I'm fearful that he would definitely have some issues in terms of growth, and he's so skinny, he's so thin, he doesn't seem to have all that energy, looks so fatigued, so parents are forcing. And what happens is when you start to force, they avoid it even more because it becomes an unpleasant experience during mealtime. And so the pressure to eat, the forcing can even worsen the aversion. There's also been an increased awareness. I think physicians are now starting to have a better understanding, and they're recognizing food aversion. They're recognizing that some of our kids are having a lot more difficulty eating a variety of foods that they would need in order to meet their nutritional intake. And then one of the biggest things, so there's a lot of research going on with environmental factors, very specifically to processed foods, flavors, and textures. So we're in the age where a lot of our food that we're feeding our kids are processed foods. If you go into the schools, let's say a K2 or a K3, and you go in during lunchtime, majority of the time you will see most of the teachers opening a canned spaghetti. And at least 50% of the children for lunch, they're eating canned spaghetti, and they're eating a lot of the chips, and they're eating a lot of the processed food. So there's a lot of research out and a lot of research going on where they think that there may be metal in the foods are sitting on the shelf life is longer. There are all these chemicals that's causing the food to last longer, that is now interfering with the sensitivity of how food tastes, and how children are actually reacting to the food. So that's interesting always with processed food. And I know there's a lot of research happening there. So what can you do in terms of managing strategies? There always should be an interdisciplinary approach. So you note mom and dad coming to you, they're complaining. You want to collaborate with an occupational therapist or a speech therapist or a psychologist or a dietitian, just so that parents could have options as where they can go to get the help. You're looking at especially behavioral interventions. Some of our kids are not always sensory. It's just having that negative experience with food that they automatically shut down. They're able to eat the various textures. It may not be a sensory issue, but because I almost choked, or I choked, or I gagged, or something happened and mom reacted in this scary way, and now I'm afraid. So it's now a behavior, it's a cycle. I'm anxious, I'm fearful around food. It's not that I cannot eat it. It's not that I'm necessarily afraid of the food. I'm just afraid if I eat this particular food, this is the response I'm going to get. And it may be an uncomfortable response or painful or it's very uncomfortable. And then you also want to refer to dietitians for nutritional support. I think a lot of our parents don't understand what balanced meal is and what it is to try to really help our kids get their vitamins and nutrients from the natural food rather than supplements. And supplements may be an option for some kids. So I think a lot of parents need a little bit direction and help with nutritional support, and definitely parent education is very, very important. I think the biggest issue for food aversion or dealing with kids that have food aversion is not the kid themselves, is not the process of getting them to explore new food. It's usually the parents. They're in panic, they are anxious. I think a lot of them have more anxiety than the kids themselves. And it's almost like, I need to get this done now. And they don't really understand that it takes time. It's a process. It's a routine. It's something that you have to make pleasant. It isn't something I'm trying to stuff some food in this child's mouth because he looks thin because I have other things to do. It takes time. So we need to ensure that parents are getting the education and they're doing the things that they need to do at home to ensure that the feeding process goes very smoothly and the kids are being exposed to all of the food that they need to. And then sensory integration therapy. So sensory integration therapy is something that I do as an occupational therapist. Is actually a subspecialty of occupational therapy, where we use a number of different techniques to provide sensory experience. So we're trying to desensitize the kids, whether it's texture, flavor, whatever it is, so that they will be more receptive to intaking a variety of food. So here are some referral pathways, just for your information. Your pediatrician, you're noticing weight loss, you're noticing some of those symptoms that I spoke about earlier. and you're doing your initial assessment, you've already ruled out any underlying medical conditions, or you've confirmed some medical conditions that this child may have. So what you want to do first is to educate your patient a little bit more on what that food aversion may be, and what does that mean in terms of getting help and what they need to be doing at home. Then you could always refer to an occupational therapist who would be able to assess sensory processing, providing strategies, work a little bit more on some of the oral motor functioning. The speech therapist can do that as well in terms of working on oral motor functioning and some of the swallowing, if that's an issue, or chewing, if that's also an issue. A psychologist in terms of managing anxiety and fear that may be associated with the food. And we have some behavioral therapists, so applied behavioral analysts, that would help to work on some of the behavioral challenges or the behavioral components that may come with food aversion. So those who just see the food and they're having a big old meltdown tantrum before they even can touch it, taste it, do any of that, there is some behavior attached to the food. And then definitely a dietitian, so that, you know, we could evaluate the nutritional intake, and they would be able to do a little bit more education for the parents. So I cannot leave, we're almost done, but I cannot leave without really expressing what occupational therapy and what our intervention is in regards to food aversions. So we do a lot of sensory-based feeding. A lot of times we tend to just push food in our kids' mouth. They don't get to smell it. They're not touching our food. So we provide a number of sensory experiences so that our kids would feel, first and foremost, very comfortable around food. So it's not a bad thing. They don't associate it with a negative experience. We use a lot of food play to reduce the anxiety and to increase the exposure a little bit. So it could be something as simple. I think last week I had a toast of bread. We got some cookie cutters. We cut out little stars and different types of things in the bread. And we had a toy horse. And I had the child feeding the star bread, whatever it was, we were pretending, cookies, to the horse. And then I would say, well, why don't you try to lick it? Just like how the horse put it in their mouth, you lick it. So we were able to get this child to lick a little bit of the bread. Okay, feed the horse again. It's so good. Yummy, yummy, yummy. Okay, it's your turn. How about you just bite a little bit? Can you push it in your mouth a little bit? Just a little bit. So through those type of play, we could get the kids to at least try a lot of different foods and food textures a little bit more without the anxiety. We're working on oral motor exercises with the jaw, with biting, with chewing, our tongue movements, being able to chew and stop and swallow and move from one cheek to the next. So all of those types of things. And we also work in collaborations with speech therapists and dietitians, because we also want to make sure that we're all on the same page, providing comprehensive care. So how can parents help? So some of the things that you can encourage parents to do is, first and foremost, model positive eating behaviors. A lot of times, I think with our generation and the times that we're in, we're not sitting at the table anymore as a family, eating our food. The kid has a tablet or is in front of the TV or running around. They're not in their high chair. So we have to create positive eating experiences, creating positive mealtime environments where we're sitting, mommy saying, this rice is so delicious. This is so good. How about you try a spoonful of rice? So creating those experiences is always good. You want to also not force the child to eat, not pressure them into eating. It takes time. It could be very, 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 very frustrating. But the more you force, the more they're going to shut down. And that's what we're trying to avoid. And then offer a variety of textures and flavors early on. I think sometimes we wait a little bit too late. And I always encourage maybe like a little bento box, a little box with little small squares You add a little bit of carrots. You could do a little bit of chips. You could have a slice of apple, maybe a little bit of applesauce. You could try different types of food or the same food in different textures. So you could have sliced apple, maybe a little bit of applesauce, maybe a little bit of applesauce mixed with strawberry. It all depends, but just offer variety and different textures and flavors from early on.
Thank you so much, Mrs. McIntosh. This was an excellent presentation. As you're aware, we have so many kids with food aversions, and we're happy for educating us and giving us some tips and tools to help move forward. So thank you once again, and we were happy to have you as a part of our Pediatric Week. Okay? All right, so
Thank you
our
for having
next
me.
speaker, thank you. So our next speaker is Mrs. Sarah Sklerter. She's a pediatric critical care nurse practitioner, and she is singing in all the way from Wisconsin. So just to give you some update on Mrs. Sklerter, she has an Associate of Science degree from Cardinal Stritch University. She also has a Bachelor of Science and a Master of Science in Nursing from the University of Alabama, Birmingham. And she is also certified with her nursing certification and also a part of the American Heart Association. She has many publications, and so she has been working in the pediatric area, also in the critical care area for many years. And so presently, she is a pediatric critical care nurse at in the pediatric intensive care unit at the American Family Children's Hospital, Madison, Wisconsin. I know she's not familiar with the Bahamas. She has actually had a session with us before with ICU monitoring, where she was able to educate some persons in our department. And so we are enthused and delighted to have Ms. Sklerter here with us. Sorry for the pronunciation, but we're more than happy to have you present this morning, and she'll be presenting ECMO in the critical care unit. And I think it's a fantastic topic. Surprisingly, Dr. Seymour, our own specialist, actually performed ECMO. So we actually had a first case of ECMO where she had to, I think it was over at Doctor's Hospital. And so it is great for us to get some education on it. So without further ado, we open up the floor and you can share your screen. And thank you and welcome to the Bahamas. I wish you could see our son, but I'm hoping you could feel, she's been here 3 times. Perfect. So I hope you feel our warmth this morning. So welcome.
My name is Sarah Schluter. I'm a pediatric critical care nurse practitioner, and I've been practicing in the pediatric intensive care now for 18 years, so a long time. Today we are going to talk about ECMO in the critical care unit. And so pediatric ECMO, the superpower that saves lives. I have no disclosures. My objectives for today's talk are to provide an overview of ECMO, the indications for its use, a review of the types of ECMO available, and to review the circuit design, to go over the contraindications of ECMO, and to do a broad overview of management while on ECMO and the potential complications associated with it. So it's just a definition of ECMO. Extracorporeal life support is a mechanical circulatory support for prolonged, though temporary, cardiopulmonary support for severe cardiac or respiratory failure. And the important word to take away from that is temporary. ECMO really is just indicated for the acute use to get you out of that acute situation when you've exhausted all of your typical medical management. But it is not intended to use for a prolonged period of time. The longest I had a patient on ECMO is 2 months, and that I would say is on the long end of things. Typically, you want to try to get your patient off of ECMO within a week to reduce the risk of complications. Now, extracorporeal life support is achieved by draining venous blood from the body, removing the carbon dioxide and adding in oxygen through an artificial lung, and then returning the blood to the circulation via a vein in veno-venous or VV ECMO, or via artery in veno-arterial or VA ECMO. So how is ECMO achieved? So ECMO cannulation, I have 2 pictures up there. One is for VV ECMO and the other for VA ECMO. And these are just one example of the ways you can cannulate a patient. So typically for VA cannulation, the preferred method is to do a cut down of the right jugular vein and the common carotid artery. This is what you would see typically for your neonates or your small infants, as this way they typically have the best drainage in return on the ECMO circuit, and you have less issues with flows. Central cannulation is usually reserved for those patients who are unable to have a percutaneous cannulation. And so those are going to be more of your patients who have recently had cardiac surgery. If they have recently had a percutaneous ECMO cannulation and then have needed to go on for a second ECMO run, you've already interfered with that common carotid artery, and typically you cannot go in that same place again. And so those would be in the instances where central cannulation would be indicated. You can also access via the femoral vein on one side and then the femoral artery on the other side of the body. You'll see this more often in your teenagers or those children, typically over the age of 10, that are a little bit bigger. The surgeons will do the percutaneous cannulation there. For VV ECMO cannulation, there are 2 different options. One is you have just a single cannula with double lumens inside that single cannula, and that goes in via the jugular vein and goes directly into the right atrium. Now, with that type of cannulation, you typically have more issues with recirculation, and your patients won't oxygenate quite as well, because if you imagine you've got the one cannula going into the right atrium, and 1 lumen's your drainage cannula, and so you're taking blood out, but then the inflow, the lumen is just a little bit further down, and so that oxygenated blood is going there, but a little bit of that is going to mix in that right atrium, and so you're going to get some recirculation there. And so those patients just typically tend to have a little bit lower saturations as a result of that. The other option is to have 2 cannulas, one in the femoral vein as the drainage cannula, and the other in the jugular vein as the inflow. And I will show you guys here. So for the VV ECMO, you can see here that the cannula in the femoral vein here is draining, going up to the pump. Then from the pump, it goes up to the oxygenator. From the oxygenator, the oxygenated blood then returns to the jugular vein. And for this example of VV ECMO here, you can see that it's draining from the femoral vein here, going to the pump, then to the oxygenator, and returning on the opposite side in that femoral artery. Now on this page, I wanted to show you kind of just what a circuit looks like. And this is a patient that I recently cared for in the pediatric ICU who was on VA ECMO. And I apologize, I don't think I did my best photography here when taking this picture. But you can kind of see here this cannula coming up here back to this pump, draining from the body, patient sitting here. And this type of pump is called a centrifugal pump. There are 2 different types of pumps that you can use for ECMO, the centrifugal pump and the roller pump. The centrifugal pump is really the one that is primarily used now. The roller pump had a lot of issues with hemolysis, and so that has kind of phased out, and most centers now are currently using the centrifugal pump. Now from the centrifugal pump, the blood will drain down through this cannula here, going back up to the oxygenator. Here the CO2 will be removed, oxygen will flow in, and then on this side here, I can kind of see the cannulas here going back to the patient on that side. Just want to point out here that this is the heater. One of the nice features of the ECMO circuit is that you can set the patient's temperature to whatever you need it to be. And then right here is the hand crank, most important part of the ECMO circuit that you want to know where it is. I am thankful I've only had to ever use the hand crank once in my 18 years in the PICU. It is something that you hope will never happen, but there are rare instances where, power goes out and you need to keep the ECMO circuit going. And so then you have to manually hand crank the circuit. And anytime you have to do that, it always seems much longer than it actually is. Thankfully, it was only a few seconds for when I had to do it many years ago. On my next slide, you'll be able to see the other portions of the ECMO circuit in terms of the control panel and whatnot. Just wanted to mention what the typical flow rates are. So for a neonate, we typically set the flow rates to be about 100 mils per kilo per minute. Now that can change by about 20 to 40 mils per kilo above that, depending on what's going on with your patient and if you need them to flow a little bit higher. For a pediatric patient, it's typically 80 mils per kilo per minute. And again, that might be a little bit more, again, depending on what is going on with your patient and also what's going on with your ECMO circuit itself. So here is the control screen. And so the control screen is where you would set your flow, which is in liters per minute. On here, you can see that it is set at 0.33 liters per minute. And this particular patient weighed 3 kilos. So we were flowing at just a little bit over 100 mils per kilo, and the patient is 2 weeks old, so a neonate. And to achieve that flow rate, we needed to set the RPMs at 1850. And really, I fortunately didn't include this on my picture. There's literally just a little control knob that you turn. And as you turn it to the right, you're going up on your RPMs, and that increases your flow, and then to the left, it decreases your RPMs, decreases your flow. Now, there are some things related to the patient and the circuit that they can also impact your flow rates, and we'll talk about that in a moment. On the right-hand side of your screen is the pressure monitoring box, and so this is a useful tool to kind of give you an idea of how healthy your circuit is. How well is your oxygenator working? Are there any issues with kinks in your cannulas or clotting or anything else that potentially could impact the flows or the return to your patient? And so I'll go through each of these just real quick. And so the drainage pressure that you see there at the top of your screen is set for this particular patient at that time was -2. Your typical drainage pressure is -10 to -20. If you have a low drainage pressure or less than -10, it can indicate that there's poor venous cannula placement. There could be clotting, or the patient overall just has a low blood volume. A high pressure greater than -20 can indicate a kink in the cannulas, excessive suctioning from the ECMO circuit, elevated interthoracic pressure. And so those are just different things to think about and to troubleshoot if you're seeing a change in your drainage pressure. The next number there is going to be your pre-membrane pressure. For this particular patient, it was 140. Typically, your normal pre-membrane pressures are going to be between 40 and 100. And this is measuring the pressure before the blood enters into the oxygenator. So if you have a high pressure, it can indicate increased resistance in the circuit someplace. It can be an indication of clotting or blockage in the tubing or in the oxygenator. In this particular patient, there were a number of small little fibrin clots in the oxygenator, and so that could have been contributing to this pre-membrane pressure being 140. There's increased risk of hemolysis and the pump itself having to work harder when this number is higher than the normal range. If there's a low pressure, it can be an indication of insufficient blood flow due to inadequate venous drainage, a pump malfunction, insufficient venous return from the patient. Now your postmembrane pressure is going to be that 126 there on the bottom. And that is typically between 50 and 150. If you have an increased pressure, it's an indication that there's increased resistance in the circuit, that the oxygenator itself is malfunctioning, again, that there could be insufficient blood flow, like clotting or obstruction within the oxygenator. If there's a decreased pressure, so less than 50, can be an indication of a pump malfunction, underperfusion, and insufficient flow. So really the key takeaway from here is just to remember that looking at these numbers is important. You always want to have an idea of where they are, where your patient typically lives, because although there are normal numbers, as we all know, each patient has their own normal. And so it's important to, look at these numbers when you first go on, so you have a baseline of where your patient is when they went on ECMO, so that you have a better idea of how they're changing. It'll give you an overall indication of how your pump is functioning, what the health of your oxygenator is, and if there's a potential problem with your cannula position. So, indications for VA ECMO. The indications for VA ECMO are going to be a progressive cardiac failure resulting in inadequate oxygen delivery and signs of end organ dysfunction. So essentially, your oxygen delivery is not meeting the oxygen demands of your patient. Another indication is malignant tachyarrhythmias. This can be, for example, malignant AET or atriotopic tachycardia, persistent VTAC, sepsis, and impending cardiovascular collapse or cardiac arrest that's unresponsive to resuscitation. And I will just say an important note here is that in general, VA ECMO is not going to be an option for a patient who had a on-witness cardiac arrest, because you don't know that downtime, and that will, as we'll mention later on, will be a contraindications for VA ECMO. Indications for VV ECMO are going to be a patient who has progressive respiratory failure that's unresponsive to your traditional therapies. And these patients typically will then develop acute respiratory distress syndrome, either caused by several things, potentially pneumonia, status asthmaticus, pulmonary embolism, congenital diaphragmatic hernia, meconium aspiration, idiopathic pulmonary hypertension, or even patients who have a persistent air leak syndrome. Now, this list is not exhaustive. There are definitely other indications, but these are the most common indications for VV ECMO. When talking about a patient or trying to decide, does my patient need VV ECMO or VA ECMO, there are definitely advantages to both to consider. Now, when it comes to VV ECMO, there are definitely some advantages to that over VA. One is you have avoidance of arterial cannulation. Anytime you can avoid being on the arterial side of the circulation, that is definitely a benefit to your patient. You have a decreased risk of stroke then. You avoid potential arterial embolization. You avoid taking away that carotid artery for future use. Typically, they end up having to tie that carotid artery off, which then can put them at, even once they're off ECMO, at a higher risk of stroke later in life. And then another advantage is the absence of the negative hemodynamic effects that can be associated with VA ECMO, such as increased afterload. Advantages of VA ECMO. The biggest one is that it offers full circulatory support. And so your patient is fully supported when you place them on VA ECMO. Contraindications to ECMO. So these are going to be things that you don't feel like your patient is going to have an irreversible cause of their disease. And so you don't want to place a patient on VA ECMO knowing that ultimately they won't survive. So if you have a poor prognosis from the primary illness, if it's an irreversible disease, if they already have a known hemorrhage, either intracranial or they're hemorrhaging anywhere else in the body, a severe neurologic insult, again being intracranial hemorrhage, already known severe stroke, if they have advanced multi-system failure. Now, that point is something that I would say can be debated amongst the team. It's really going to depend on how advanced that multi-system failure is and whether or not that's a true contraindication for the patient. Because a lot of the times, once the patient gets on VA ECMO and then they have adequate oxygen delivery to the entire body, they can meet the demands, you will a lot of the time see that multi-system failure improve. Now, that's not always true. And so that's why it tends to be a debate amongst the team prior to going on. In terms of size, generally less than 34 weeks and less than 2 kilos are contraindications, just for the mere fact that the patient is so small and we just don't have the cannulas to cannulate a patient any smaller than that. I believe the smallest patient I've seen cannulated is maybe about 2.1 kilos, I believe is the smallest one I've seen cannulated. All right, so now we'll jump into kind of the general management of the patient. So you were able to get the patient on ECMO. You can take your deep breath for a second because you got out of that acute phase, you got your patient on, but now you still got more work to do. And so thinking about the overall patient, and we'll go system wide just because I think a little bit easier to touch base on all the things. So starting from the top, we'll do neurologic management. And really the biggest thing when it comes to neurologic management of these patients once they are on VA ECMO is your sedation, analgesia, and how they're tolerating the ECMO circuit itself. So in your neonates in particular, sometimes if they are stable, they're having a good run, you really can have them quite awake and they tolerate that really well. And it's also a great indicator of what their neurologic status is. If you have them awake and looking around, you don't have to worry so much about not knowing what's going on in their head, if they're having a complication or not. So we prefer to have our patients at least a little bit awake so we have some type of neurologic exam on them. Now, in some patients, that is not tolerated and they need to be sedated and paralyzed to safely be on VA ECMO and to adequately flow. So, one of the key things to remember for these patients is that now you have this big circuit, all your blood's going not through just your patient, but also through the circuit. And so your pharmacokinetics and your volume of distribution is going to be significantly different when you have a patient on ECMO, because now all that drug is circulating through the circuit. And so for medications that are really lipophilic, they are going to really stick to the circuit, and the circuit's going to eat up a lot of that drug, and your patient's not going to see it. So medications like midazolam, fentanyl, propofol, they're not going to provide as well sedation and analgesia for your patient, because those medications in particular will stick to the circuit more than others. And so you will definitely notice needing higher doses of those if those are chosen. The medications that typically work best are morphine and Precedex, just because those don't stick to the circuit as much. When it comes to imaging, I included that just to point out that typically for our patients, especially primarily for the neonates, is that we will typically get a head ultrasound every day, monitoring very closely for complications of intracranial hemorrhage. Other imaging, if we have concerns that there's a neurologic injury, we will take these patients to a CT scan. Now, as you can imagine, that's quite the journey to CT, and always a little bit nerve-wracking moving your patient with cannulas in place. So we try to avoid that as much as possible, but always do what is best for your patient. And obviously, if you have a new concern for acute intracranial process, you need to make that trip as safely as possible. For all of our patients, we will put EEG in place, again, just to help monitor for any seizure activity that could be an indication for a new neurologic process. We always have our neurology team involved for these patients that'll come do as best baseline exam as they can, knowing that it's fairly limited, because at that point in time, your patients are likely to be well sedated. And so we do just like to have them involved in case we do have any new concerns that come up. For cardiovascular management, there's not a whole lot typically that you need to do, because if you're on VA ECMO, you have your circuit doing most of that work for you, right? And then for the patients on VV ECMO, their heart functions well, because otherwise you wouldn't have chose VV ECMO. for that patient. So typically, when you first go on, your vasopressor and inotropic needs are usually a little bit higher when you're first going on and when you're trying to come off. You want to monitor for adequate end organ perfusion. And if you're needing vasopressors and inotropes, I would say typically we use epinephrine and vasopressin. And for inotropic support, that would be like your milrinone, your dobutamine, and that'll just help improve your contractility. And again, typically if you're on VA ECMO, you're going to need these more often when you're trying to come off. Now, an important thing to keep in mind for your patient is that SVR directly impacts the flow of your ECMO. And so if you have a patient who's in a high SVR state, your ECMO flows are going to be lower. And so in that instance, you might need to use medication like nicardipine or nipride to lower your SVR so that your ECMO flows improve. Now, the high SVR state may be if your patient is wide awake. And then, so always for our patient, if they are in a high SVR state, we kind of look at, what's going on. Do you start with sedation? Okay, that didn't work. And then you move to thinking about needing nicardipine or nipride or something in that realm to help lower the blood pressure. Now, if they're in a low SVR state, your flows are going to be much higher. And if they're higher than what you want them to be, you can always turn down your RPMs to get your flows more to where you want it to be. Sometimes you need to kind of tighten them up a little bit, and so a little bit of low dose epi just to help with that. From a pulmonary standpoint, really the goal is to be lung protective. You don't want to use high vent settings once you're on ECMO, either VV or VA, because the machine is doing that work for you. And so really what you want to do for these patients is to ensure that you're not going to get a lot of collapse, and you don't want to beat up their lungs while they're on ECMO, because it's supposed to be a time for the lungs to rest and recover. And so typically we'll put them on we call them resting settings. So for example, if you had a patient on SIME PRVC mode of ventilation, you would set kind of a low rate. Typically we do a rate of 10, set your PEEP at 10, and you set your pressure support at 10. And tidal volumes, 6, 7 per kilo, really just enough to help keep the lungs open and expand it. So they're doing a little bit of work, but mostly resting. Now, when it comes time to come off of the ECMO, you really know whether or not your patient is ready because you can just turn down the FiO2 and the sweep gas in your circuit. And if your patient is starting to clear the CO2 on its own, you're needing lower and low oxygen on your pump, that's an indication that your patient may be ready to come off from a respiratory standpoint. And so from that standpoint, it's a lot easier to know whether or not your patient's ready to come off VV ECMO than to know if your patient's ready to come off of VA. Sometimes these patients do collapse parts of their lungs. The right upper lobe tends to be the most often culprit. And so sometimes doing airway clearance is important for these patients. You can do the gentle vibes or chest physiotherapy to help keep open the lungs. It's easier to do that on patients that are percutaneously cannulated than those that are centrally cannulated. Sometimes these patients really develop thick mucus plugs in their airways, and a bronchoscopy is needed prior to being able to come off of ECMO. Definitely had several patients who've needed bronchoscopies to kind of help open up get all that mucus that's sat down there out before they are ready to come off. And these are things you want to think about and consider to try to optimize your patient as much as possible before trying to come off of ECMO. Now, hematologic management. This is one of the biggest challenges when it comes to ECMO. It's also one of the things that causes the most complications. And so it's the thing that you want to try your best to get right. Although, like with all things, ECMO is unpredictable and despite trying your best, you can still have complications with this. So typically, on fractionated heparin is used as the default anticoagulation therapy for these patients. Bivalirudin is a newer anticoagulant that is being used at different institutions, but across the board, heparin is typically what is used. Now, different programs have different anticoagulation guidelines that they follow. They follow different markers of therapeutic anticoagulation. At our institution, we follow anti-10As when adjusting the heparin. And then we set different anti-10A goals depending on how the patient's doing, how the ECMO circuit itself is doing, whether or not we need to be higher on our goals or not. And then there's different transfusion thresholds that we set. We really try to limit the amount of blood products that we give these patients. One, in that it tends to, if you're needing more and more blood products, it tends to cause more clotting and fibrin in your circuit itself, makes the circuit unhealthy, leading to the potential need for changing it out. So we really try to avoid that as much as possible. And also, you want to try to limit the volume you're giving your patient. And so, anytime you're giving blood products, it tends to be a decent amount of volume that you want to avoid. Now, that being said, you have to protect the patient ultimately. And so, things that we typically set will be a hemoglobin level. Typically, we'll target a hemoglobin over 10 for most patients. For platelets, we typically target over 75. Now, if they're not having any bleeding, your pump's really working well, you're not worried about an intracranial hemorrhage at all, we might even set it as low as 50. For patients that have a small intracranial hemorrhage, we may bump it up to 100 just to protect them a little bit more. Fibrinogen typically will target over 100, and those are the typical thresholds that we'll set in terms of transfusions. Fluids, electrolytes, and nutrition. Obviously, nutrition is very important, and we want to try to provide that to the patients as early on as possible. Obviously, enteral nutrition is best if you're able. For your patients who are well supported on VA ECMO, it is definitely beneficial to do enteral feeds as soon as possible. Again, keeping in mind where their volume status is. And that really tends to be our biggest limitation when it comes to nutrition on these patients is how much additional volume can we give them, knowing that we're also trying to take volume off. And so a lot of the times what we'll do is some combination of enteral feeds with TPN to really optimize nutrition as much as possible, to optimize healing as much as possible. Now for our fluid restriction, we typically like to target about 2/3 maintenance fluids for these patients, really trying to limit how much we can put in so we can these patients tend to have big inflammatory response. They have a lot of third spacing. And so you really want to try to get all that off before your patient is able to come off a VA ECMO. And so we'll, again, like I said, 2/3 maintenance is typically what we'll set. And knowing that, thinking about, okay, what are all my ins, and really looking at that tends to be extremely helpful. And so all of your continuous infusions, making sure those are concentrated as much as possible, really tends to be the place where we can save volume a lot for these patients. Electrolytes, you want to make sure that you are being cardioprotective, keeping your calcium, your potassium, your magnesium all at a normal level, again, to be cardioprotective for these patients. And then renal function, really monitoring that closely, as that's a big indicator of how well you're oxygenating the patient and whether or not you're meeting those demands. For patients who develop a acute kidney injury because of the event that led to VECMO, you typically will see that recover after a couple of days on VA ECMO. However, there are a few patients who end up needing to be dialyzed while on VA ECMO because their kidneys really took a big hit in whatever that event was leading up to VA ECMO. And one of the things that we can use with the circuit is to, you can't use it truly as dialysis, but you can use the ECMO circuit to pull volume off. And that's done where the perfusionist adds extra connections, and then you can set a pump to pull off a certain amount of volume every hour. And we definitely use that on patients who have bad renal function, are not responding to our diuretics, and who are becoming extremely edematous. Now, infection. Again, guidelines differ from institution to institution. We'd like to get blood cultures on a daily basis just because we do set the temperature for the ECMO circuit, and so your patients typically will not spike a fever. And so really monitoring these patients closely for infection is extremely important. We'll typically do prophylactic antibiotics after cannulation for at least 48 hours, longer if it's a central cannulation. For those patients that are centrally cannulated, you will continue the antibiotics for as long as their chest remains open. You want to consider fungal coverage for these patients. Typically, we say if we're on day 3 to 5, as of the time frame that we'll consider adding fungal coverage. You want to consider the underlying disease state of the patient, and was sepsis the reason why the patient needed to go on VE ECMO? That will obviously guide your antibiotic choices. Once you're on circuit, and again, because your temperature is being controlled, things that can be a sign of a new infection are leukocytosis, leukopenia, and thrombocytopenia. And in general, a new infection on ECMO is associated with worse outcomes. Complications, because like all things, there are downsides for everything we do in medicine, and there are definitely some severe complications that can be associated with ECMO. The number one thing being bleeding. Typically, you'll have, if you have bleeding, it'll be at your cannulation sites most often. And so controlling that, again, if you're having a lot of bleeding, that leads to a lot of blood products, which can lead to to issues with clotting and fibrin within your oxygenator, leading to the need for a pump change. And every time you do a new pump change, you have a new inflammatory response that, again, it just kind of creates one problem on top of the other. Thromboembolic events is a complication that can happen with ECMO, which in this picture here is a picture of a patient who developed purpura fulminans while they were on VA ECMO. And that happens, unfortunately, just because of the oxygenator. It's foreign material and blood goes through it, and then the patient develops DIC. Now, for these patients who develop thromboembolic events, they have significant morbidity as a result of that, sometimes even mortality, because it can end up leading to needing to come off of ECMO before the patient is ready. Infection can be a complication because, again, you have all this plastic and hardware coming out of the body, which is a nidus for infection. Neurologic injury is unfortunately a very common complication of VA ECMO. You will have patients develop intracranial hemorrhages, strokes. I've had some that have been life-limiting and others that have been very minor and have caused minor impact to the patient. Pump failure. That's kind of self-explanatory. For some reason or another, your pump stops working and you need to emergently change it out. Most often it's as a result of clot that formed within your oxygenator or a clot that formed at your cannula, inflow cannula, that causes the pump to stop working. Renal dysfunction, again, can be a complication. And then third spacing and edema, you see that with all of your patients that go on VA ECMO or VV ECMO. And again, that's just because the big inflammatory response that happens from going on. So when is it time to come off? I included a quote from Dr. A. Dr. Nagastopoulos, one of our CV surgeons here in Madison. He likes to say with every patient, you know, you waited too long to try when you had your first complication. And so that's something that I always have in the back of my mind. And I'm always thinking, is today the day that I can get my patient off? You know, what is going to be modifiable that one more day on is going to be more beneficial than harmful? And so you always want to be thinking, what can I modify that is going to increase the percentage of being successful and coming off? That it's going to be worth staying on another day, because with each day, the ECMO raises your chances for complications. And so as soon as you put your patient on ECMO, you need to think about, okay, when can I take them off? And that is definitely something our CV surgeon says to us all the time and really wants us to be thinking about in the ICU. Outcomes. So this data is from the ELSO registry, and it's the data from North America over the last 5 years. And I've highlighted a few things here. The neonatal cases, there's been about 5,000 in the last 5 years, and their survival to discharge or transfer is about 60%. For pediatric patients, the total number of cases is close to 9,000, and their survival is also around 60%. So outcomes are roughly the same between your neonatal and pediatric patients, about 60%. And you can see that the patients who need it to go on for a pulmonary reason tend to do better than those that need it to go on for a cardiac reason, with their survival being closer to 70%. All right, so I have a couple case studies coming up here to make this a little bit more interactive. And what I want to get from the group here is what type of VA ECMO do you think this patient would need? And that's going to be for case study A and for case study B. So case study A is a 12-year-old male with hypoplastic left heart syndrome. They are post-op day 5 from their stage 1 palliation, the Norwood operation. They develop severe atrial ectopic tachycardia with rates up to 250 at times. They're treated with an amiodarone bolus and a continuous amiodarone infusion, esmolol infusion. However, the atrial ectopic tachycardia is resistant to treatment and progresses to profound hypotension and cardiac arrest. So what type of ECMO do you think this patient would require? And I can't see the chat, so anyone just please feel free to say what you think. All right, so this patient would need VA ECMO because they're going to go on for a cardiac reason. They have this atrial ectopic tachycardia that is prohibiting adequate cardiac output, and so they're going to need to go on to be fully supported from a cardiac standpoint. This particular patient ended up being percutaneously cannulated, had about a 3-day ECMO run, came off, and then unfortunately that atrial tachycardia came back again. And again, very difficult to treat and was resistant to our traditional therapies. And unfortunately, this patient had to go back on for a second ECMO run via central cannulation. All right, our next case here is a 3-month-old man with congenital airway malformation, CPAM, who is status post a left lower lobe resection. They are found to be influenza A positive on post-op day number 2. They developed acute respiratory distress syndrome and then developed a large pneumomediastinum. This patient ended up requiring VV ECMO. Was on VV ECMO just for a few days and then was able to transition off. Was on a high frequency oscillator for a few days and then transitioned to your traditional mechanical ventilator. Now, this case study is a patient that I'd like to think about, or have you all think about, would this patient actually be a candidate for ECMO? So it's 11-month-old male with a past medical history significant for congenital heart block, secondary to maternal lupus, requiring a permanent pacemaker placement. Patient went home, did well for several months, and then unfortunately developed severe pacemaker-induced cardiomyopathy. They were admitted with progressive heart failure symptoms. Unfortunately, their clinical status deteriorated quickly, requiring the need for ECMO support, but they were also found to have disseminated fungemia prior to going on. And so, would this patient be a candidate for ECMO? Ultimately, the decision was made to put this patient on VA ECMO, knowing they had disseminated fungemia, and knowing that the likelihood of clearing this would be, patient didn't have a high likelihood of clearing this fungemia. However, in order to save this patient's life, we put them on VA ECMO, and we were going to try. And so after treatment with antifungals for several months, we were able to clear the fungemia. The patient remained on VA ECMO during that time. And once we were sure that the fungemia was cleared, we transitioned this patient to a ventricular assist device and bridged that patient on a ventricular assist device to transplant. Now, case study D is going to highlight your own superhero, Dr. Seymour. So Dr. Seymour placed this little 19-month-old with a history of tetralogy of Fallot, status post-repair, presented with respiratory distress following an episode of emesis. They were admitted with presumed aspiration pneumonia, requiring high-flow nasal cannula, acutely developed respiratory distress, requiring intubation, found to have significant laryngeal edema at the time of intubation, and then they were very difficult to ventilate, had CO2s as high as 200, despite all your traditional therapies such as paralysis, albuterol, magnesium, and airway clearance. And so this patient was placed on VA ECMO and was successfully transported to outside hospital. And then the patient was able to come off ECMO and is doing well. Just list my references.
Hi, so good morning, and thank you to the Department of Pediatrics for inviting me to talk today about the approach to the adolescent gynecology patient. I have no disclosures. And put this down here. So the objective of this talk is to basically discuss the approach to the adolescent patient, to look at common presentation and in adolescent gynecology, and also to review the significance of the legal knowledge in adolescent gynecology. So why adolescent gynecology matters. Adolescence is a transitional period with significant physical, emotional, and psychological changes. Addressing gynecological concerns early promotes lifelong health and prevents long-term complications. So the collaboration between pediatricians and gynecologists is important. Key principles of adolescent care is establishing trust and rapport, respecting confidentiality and understanding legal considerations in the Bahamas, and also creating a safe and non-judgmental space. So we will be taking a general look at the approach to the adolescent patient in terms of communication strategies. So you would want to begin the consultation with both the adolescent and the parent, but then you would want to transition to a one-on-one with the patient to encourage open dialogue. And you want to carefully explain confidentiality policies, including any legal limitations to build trust. And so in my practice, when I see the patient, at the beginning of the interview, I would tell both the patient and the parent or guardian that what we discuss with the patient and I discuss, it's confidential, however, it's not secret. And if I find that there's any information that puts the patient at risk, I would have to disclose this information not only to the parent, but in some instances to the authorities in the case of sexual abuse, assault, that sort of stuff. So in communicating with the adolescent, you want to use age-appropriate, non-medical language, and you want to start with open-ended questions. For example, how can I help you today? Do you have any questions about your health or your body? Admit. Okay, so in terms of the history taking, you want to use the PEDS framework. I'm sure you guys are very familiar with this. Assess the home environment, education and employment, the patient's eating habits, activities and peers, drugs, alcohol, and smoking, sexual activities and relationships, suicide, and safety. You want to look at if they have any abuse, risky behaviors. In terms of the physical examination, you want to explain the purpose of the exam to the patient and obtain consent, respecting the adolescent's autonomy. You want to offer a chaperone. And for me personally, if the parent is not in the room, I would ask the nurse to be present. You want to conduct the exam in stages, allowing the patient to remain covered when possible. And you want to focus on the areas, you assess your TANA staging, breast development, the external genitalia, and you want to defer the pelvic exam unless it's necessary for, except in cases where there's unexplained pain, abnormal bleeding, or where there's any suspicion of pelvic pathology. Waiting room, admit. Sorry. All right, so let me put this down. I'm not sure if someone can admit the participants for me. That's okay. So common presentations in adolescent gynecology. So primary amenorrhea, and this is failure of menarche by the age of 15 or more if you haven't seen the period more than 3 years post-dilarche, which is breast development. And the causes for this can be anatomic anomalies such as your imperfect hymen, your transverse vaginal septum, can have hormonal imbalance such as PCOS, or your hypothalamic amenorrhea. And with the hypothalamic amenorrhea, causes can be stress, weight loss, and chronic illnesses, also low energy. So if you have excessive exercise, athletes, and also eating disorders, which is a common disorder in the adolescent population. So these things can contribute to primary amenorrhea. Genetic causes such as your Turner syndrome and also your Müllerian agenesis can also be a cause of your primary amenorrhea. So in terms of workup for these patients, you'd want to, you do your history and your examination, assess the TANA staging. You would want to do a pelvic ultrasound to assess for your structures such as the uterus, ovaries, the presence of the uterus, ovary. You want to do a pregnancy test in the adolescent patient if they are sexually active. And then you also want to do your hormonal evaluation, your FSH, LH, prolactin levels, also your thyroid levels, as these can be a cause for primary amenorrhea. And you want to consider doing an MRI of the brain if it is that the prolactin levels are elevated, to rule out any pituitary tumors. And your karyotyping, because this could be a cause of your primary amenorrhea. So other presentations, dysmenorrhea. So dysmenorrhea can be primary, functional, and this is when you have painful menstrual cramps without an underlying cause, and it typically starts around 6 to 12 months after the onset of the menses. And secondary dysmenorrhea could be as a result of endometriosis or pelvic inflammatory disease. which is as a result of an infection by sexually transmitted diseases. So your workup for these patients, you'd want to do a pelvic ultrasound or possibly an MRI, urine studies, and you would want to do your nucleic acid amplification test for any sexually transmitted disease. In terms of the management of these patients, you would treat with, based on the etiology. But generally, you'd want to manage with NSAIDs, for pain management. You'd also want to consider the TENS machine, as this can assist with reducing the it can assist with reducing the pain. Consider hormonal therapies and also lifestyle changes such as regular exercise and dietary adjustments, as these can contribute to helping with your dysmenorrhea. So a common presentation is heavy menstrual bleeding. And in this, you'd want to consider bleeding disorders in the adolescent patient, your von Willebrand disease. And in terms of workup for these patients, you would want to do your CBC, your ferritin, your PT, INR, as these can be out of range with any kind of bleeding disorders such as your von Willebrand or your factor VIII deficiencies. In terms of the management of patients with heavy menstrual bleed, you may want to consider your combined hormonal contraception, your tranexamic acid, and also iron supplementation. So in terms of assessing heavy menstrual bleeding, the definition is that is any excess blood loss that interferes with physical, emotional, social, and material quality of life. And what we normally talk about is the rule of eighths. And this is 80 mils of blood loss, more than 80 mils of blood loss per day, more than 8 days of bleeding, more than 8 pads per day, and or more than 1 pad per hour with clots and flooding. So vaginal discharge and infections. So there's physiological leukochoria, and this is common during puberty, and you would reassure the patients if there is no signs of infection. So vaginitis, the cause of vaginitis could be bacterial vaginosis, yeast infections, and in persons, adolescents who are sexually transmitted disease. In terms of the workup for these patients, you would want to do your wet mount, can do pH testing and STI testing. And the management would be tailored antimicrobial therapy, so whichever organism is present. So a lot of patients would present for contraceptive counseling, and you'd want to discuss contraception based on their medical history and their lifestyle. You would want to give them options, your combined oral contraceptions, progesterone-only oral contraceptions, your vaginal ring patches, depot implants, and IUD. You want to emphasize dual protection, meaning you want the contraception as well as STI prevention. And in terms of what tools we would use to help guide us in terms of determining which contraceptive method is the best, there are 2 tools. There is the WHO medical eligibility criteria, and this is something that you can download, an app that you can download. And there's also the CDC contraception app. And the CDC contraception app has recently been upgraded in 2024, because previously there was no guidance for persons who had renal disease. So the CDC would give guidance in terms of which contraception is best for persons who have renal disease. Both are user-friendly. I prefer the WHO, but the CDC, like I said, that gives guidance in terms of persons who have renal disease. So your special considerations, adolescent sexual health, You want to address STI prevention, and also you'd want to discuss HPV vaccination. You want to normalize discussions about sexual health and educate about safe practices. You'd want to look at the mental health and assess for eating disorders, depression, anxiety, as this also can influence menstrual health. And you'd want to be inclusive and respectful of the LGBT community and in adolescence, and you want to address concerns specific to transgender and non-binary youth. So the significance of legal knowledge in adolescent gynecology. So you want to understand the legal landscape. So understanding the legal landscape ensures ethical and lawful practice. It protects the right of the adolescent patients and healthcare providers. So here in the Bahamas, the legal accountability is 18 years of age, and the legal consent to sex in the Bahamas is 16. So the implications for medical consent, individuals under 18 are considered minors and require parental or guardian consent for medical treatments. Confidentiality and privacy. Healthcare providers must balance confidentiality with legal obligations, and providers should be aware of circumstances that may require breaching confidentiality, such as cases involving abuse or threats to the patient's safety. So access to contraceptive services. The availability of contraceptives is available free of charge at community health clinics. Condoms are easily accessible. And then you have the O-pill, which is a progesterone-only contraception, and this is available over the counter. And actually, I was pleased to see it in a few pharmacies, and when I spoke to the pharmacist, they said that they still have to come to the pharmacist to get it, but you don't need a prescription to receive the O-pill. So in terms of the adolescent access, adolescents are encouraged to seek services from the Adolescent Health Center, which specifically targets their needs. Parental or guardian consent is required for medical treatment. So, so adolescents can go to the Adolescent Health Center, but for services, there must be a parent or guardian. So in terms of your ethical considerations, you want to ensure that the adolescent patient understands the nature and implications of medical treatments. Even when legal consent is provided by the guardian, the patient's assent should be sought. And working with legal experts, social workers, and ethicists can aid in navigating some complex cases. So we're going to look at just a few cases in terms of the common presentations. And these slides were obtained from ACOG. So there's an emergency, you have emergency MD calls. I have an 11-year-old with abdominal pain, and we did an ultrasound. She had a huge fluid collection in her vagina. I'm pretty sure she has an imperfect hymen. So on examination, this is what we see. So this appears to be an imperfect hymen. And based on the ultrasound findings, there was a fluid collection in the vagina. So in terms of the treatment, you want to incise and you want to excise the excess tissue if needed and reapproximate the mucosal edges. So you might have a presentation such as this, where the opening, the tissue seems a bit thicker than the previous picture. And in this case, are we so sure of the diagnosis? Because it may not be an imperfect hymen. So it may be a transvaginal septum. And in this case, if the tissue looks thick and if it looks higher up in the vagina, you'd want to consider that it is a transverse vaginal septum. And you would probably want to do an MRI. So why is this important to try and differentiate between a transvaginal septum and an imperfect hymen? It's because the treatment is very different. You'd want to use laparoscopic guidance in terms of repair, and you want to incise the septal tissue. And also with these patients, if the surgery is not done by the right person, person who is trained in performing these surgeries, then you would have high restenosis rate. And furthermore, after the surgery is performed, these patients will have to use vaginal dilators to prevent restenosis. So next case, a 14-year-old presents to the ED with an HB of 4.6, with a history of fainting in the shower. She's not currently bleeding, but she had a period 3 weeks, had a period for 3 weeks. So in terms of abnormal bleeding, you have your palm Cohen, you have your structural causes, which could be a polyp, your adenomyosis, fibroids, malignancy, or hyperplasia. And then you have your non-structural causes, coagulopathies, ovulatory disorder, endometrial disorders, iatrogenic, and not otherwise classified. So up to 30% of girls with heavy menstrual bleeding will have a bleeding disorder. And so you would want to do your von Willebrand disease workup, even if these persons are on OCPs containing estrogen, because estrogen can affect your clotting profile. So you have, in terms of the labs, it won't affect the results of the labs. So in these patients, adolescent patients, in terms of abnormal uterine bleeding, you want to consider your HPO immaturity, because that's a big cause of the abnormal bleeding. PCOS is also a big cause of the abnormal bleeding. And then you have your structural, and you'd also want to consider in these patients endometritis, those that are sexually active. Endometritis with a chlamydia gonorrhea infection can result in your abnormal bleeding. In terms of the treatment for acute bleeding, there is your conjugated estrogen, which is given IV inside your ER department. You can also give your estrogen, your 50 micrograms of your ethanol estradiol. There you can give your medroxyprogesterone, 20 milligrams, and you give that every 6 to 12 hours. And then you can also give your norethindrone, sorry, that's your Primalute, and you give 5 to 10 milligrams every 6 hours. And you can consider giving your tranexamic acid and your aminocarproic acid as well. So this is in terms of the acute management, your Provera that you can give. You can also give your Depo-Provera and add your Provera 20 milligrams 3 times a day for 3 days. So in terms of the tranexamic acid, although there's a theoretical increased risk of thrombosis when antifibrinolytics are administered with estrogen, an actual increase in thrombotic events has not been documented when combined with therapy. And combined therapy may be appropriate in acute setting when other therapies have not controlled the bleeding. So you can give your tranexamic 1,300 milligrams 3 times a day for 5 days. As mentioned before, endometrial causes, your endometritis could be a reason, and you want to test for your STIs. And your iatrogenic causes, so hormonal contraception is an important and frequent cause of AUB in teens. So patients may miss, if they are on birth control, they may report missing pills, and this can contribute to abnormal bleeding. So what works best for chronic AUB in teens? Patient preference shared decision-making, combined contraceptive methods. So bleeding profiles are favorable overall for extended cyclic over monthly cycles. So with the extended cyclic, that's when you give the OCPs without giving the placebo. So they would can take it continuously for 3 months, and then they would either break for the week to allow the period to come down, or they can take the placebo pills. Your LARCs are something to consider. It's actually, persons may ask, is the IUD acceptable and reasonable in the adolescent patient? And it is. It is a good form of contraception, but it also is a good method for chronic AUB in teens. And then you have your Primalute, your norethindrone acetate, which has 80% success rate in cessation of bleeding within 7 days. So your non-hormonal therapies for heavy menstrual bleeding, your NSAIDs, and this is associated with 25 to 40% reduction in blood loss. Your tranexamic acid is also, like I mentioned before, it's helpful for these patients. And you don't want to forget your iron therapy. So if they are not acutely anemic, there's no need for rapid increase in HB. You want to give 40 milligrams daily or 60 milligrams every other day. And if it's acute or if there's an upcoming surgery, you want to give 120 milligrams every other day. And you want to take it with orange juice as this increased absorption. So next case, a 13-year-old presents to the ED with severe abdominal pain, nausea, vomiting. The pain started 2 days ago, and when she came to the ED, pain started 2 days ago when she came to the ED. There was normal imaging. She was sent home with reassurance, NSAIDs, and Miralax. The pain waxed and waned, but woke up from sleep, so she came back to the ED. So when they did the imaging, they saw a follicular ring sign. All the follicles would line to one side of the ovary. And they also saw the whirlpool sign. And this is just a coiled vascular pedicle. So what we have here, took her to she had laparoscopy surgery, and we see here that the ovaries are torn. So in some instances, in some patients, the pain may be absent. In terms of the examination, you might have benign abdominal exam, and they may have unremarkable imaging. But the red flags are a wax and waning pain. If the pain is severe, then you definitely want to consider torsion. So this is just a composite scoring. They found that when they assessed a group of adolescent patients, when they looked for vomiting, adnexal volume, the adnexal ratio, and when they, in the premenarchal and the menarchal patient, when they had a score of greater than 4, about 25% of patients had torsion. And if the score was between 2 and 3, about 3 to 5% of them, 3 to 10%, of them had torsion. So torsion is one of those things that imaging may not be a diagnostic. The symptoms may not help in terms of making that diagnosis, but you just have to have that clinical suspicion. And in terms of making the diagnosis, if the patient comes in with that wax and waning pain, then you should take them to theater to have direct visualization through laparoscopic, doing a diagnostic lab. And, because you'd want to treat as soon as possible in order to save the ovary. So the pediatric adolescent gynecology, their torsion tips. The adnexal can torse without a cyst. Paratubal cyst can torse without evidence of normal blood flow to the ovary, so which limits the diagnostic role of ultrasound. And also young patients often present with nausea and vomiting, which can delay the diagnosis. So the adolescent patient, the holistic adolescent-centered care approach is important, and the collaboration between pediatricians and gynecologists is imperative to optimize outcomes. And you'd want to understand the legal landscape to ensure ethical and lawful practice in this unique population. And so I just included here, in terms of my visit, my intake sheet. Like I said, I would, when I see an adolescent patient, I would just introduce myself as a gynecologist and inform them that what we discuss is not secret. And then I would have to inform the authorities if there are any reportable cases. do your history, your physical examination. You'd want to educate during the visit, talk about menstruation, contraception, sexual health. You want to discuss your home life, education, diet, exercise. That's your head history taking, and then just address any questions and concerns. So these are my references.
So thank you for that wonderful introduction, Dr. Saunders, and thank you for having me or inviting me to speak at Pediatric Week. It's an honor. So let's get into some pediatric iron deficiency anemia. Okay, so I have no financial relationships relevant to this topic to disclose. And by the end of the talk, I hope that you guys will be able to recall the typical presentations and etiologies of iron deficiency anemia in children, to discuss iron supplementation and the best approaches to oral iron administration to optimize absorption, and also to be able to talk about when to consider parenteral iron supplementation in children. So anemia is a global health burden. It affects 33% of the world population and accounts for about 8.8% of global disability. Although the etiology of anemia is multifactorial, iron deficiency is considered to be the most prevalent cause globally. A systemic analysis of the global anemia burden from 1990 to 2010, which looked at mild, moderate, and severe anemia for 187 countries, including both sexes and over 20 age groups, found that young children had the highest prevalence of anemia in all regions and the highest mean severity in all low and middle income regions. Alarmingly, this group, young children, was the only age group with increased anemia prevalence between 1990 and 2010. Sorry, I'm trying to move my slide. Okay, and so from that same publication, this bar chart, which highlighted the global and regional cause-specific anemia prevalence from 1990 to 2010, showed that among both sexes, throughout every region examined, iron deficiency anemia, which is seen in the green bars, remains the most common cause of anemia globally. And again, when they examined the burden of anemia by age, by its prevalence in graph A, and by the years lived with disability in graph B, they identified that those children younger than 5 had the highest prevalence and the total years lived with disability from anemia. Unfortunately, the data of childhood anemia in the English-speaking Caribbean is not as robust as in the previous study. And the specific statistics regarding iron deficiency anemia is an area that needs further research. However, there is some data. According to a PAHO publication in 2019, the regional median anemia prevalence in children aged 6 months to 59 months was 16.5%, which was equivalent to about 12 million children with anemia. Across the countries of the Americas, the prevalence of anemia in children was highest in Haiti at 60.1% and lowest in the United States of America at 6.1%. And in the Bahamas, according to World Health Organization statistics, anemia prevalence ranges somewhere between 29 to 30% among children under age 5 years, with iron deficiency anemia being the primary etiology. So why is this important? Well, because children with iron deficiency anemia are at risk for long-term developmental disadvantage as compared with their peers with better iron status. As we have recognized, the age group most vulnerable to the detrimental effects or long-term effects of anemia are children under 5 years, the preschool age group. But even in children with anemia in infancy, they're found later on in life to have lower scores on tests of motor and mental functioning at school. So even outside of the obvious detrimental physical effects, such as weakness and decreased exercise tolerance, early correction of iron deficiency anemia is needed to limit the neurodevelopmental deficits that can develop. Sometimes these changes are irreversible abnormalities resulting from a deficiency at a critical period of growth and differentiation of the brain. Other studies have also found that iron deficient children can experience growth restriction with a lower height for age and weight for age scores than iron sufficient children. And additionally, preschool age children with iron deficiency anemia show altered affect and behavior. So when we think of iron deficiency anemia, we often think of two major groups in pediatrics who are at increased risk for developing that complication. The first group is the toddler with excessive cow's milk intake. So these children are rapidly growing and often additionally have iron deficient diets. They are often otherwise healthy. However, specific questioning will give a history of a child who is picky with food. They probably prefer to drink milk. They often prefer to drink the milk from the bottle rather than a cup. And a detailed history typically reveals a child's diet is deficient in iron due to grossly excess cow's milk intake, and that they may have symptoms such as pica, which we'll get into a little bit later, irritability, little appetite for meat, vegetables, or other iron-containing foods. Excessive cow's milk intake is a strong predictor of iron deficiency because of its low iron content, less than 1 milligram per liter. It's poorly absorbed from the gut. Iron in cow's milk is less than 10% bioavailable when compared to 50% of the iron in breast milk. It causes reduced intake of other foods, as I said, and suboptimal absorption of medicinal iron supplements, and in severe cases can cause occult gastrointestinal bleeding and milk protein enteropathy. So I'm always cautious in questioning parents of toddlers who are prescribed ferrous sulfate, and you expect that these toddlers should respond to ferrous sulfate. They don't have any other risk factors for iron deficiency anemia or malabsorption, but they have suboptimal improvement in their hemoglobin concentration on repeat analysis. And when you ask the parent specifically how the iron is given, the response is, oh, I put it in the milk in the morning, or I put it in his bottle. Well, there are two problems with this. The milk itself impairs the iron absorption. And two, if he doesn't finish the bottle, he doesn't get the full dose of the iron. And then, as I said, excess cow's milk intake limits the intake of other iron-rich foods. So again, the American Academy of Pediatrics recommendations are that infants under 12 months get breast milk or iron-fortified formula is recommended instead of cow's milk. Children over 1 year limit cow's milk intake to 16 to 24 ounces a day. I like to say 18 ounces, but to 24 ounces a day to ensure that they have enough room for iron-rich foods in their diet. And consider including iron-rich foods such as meat, beans, fortified cereals, and leafy greens, and pairing them with vitamin C-rich foods such as citrus fruits to improve iron absorption. And they also recommend universal screening for iron deficiency at 9 to 12 months, particularly for those who are at risk. And if risk factors are identified, then we should be sending a hemoglobin. So the other major group that comes to mind when we think about iron deficiency in pediatrics is the female with heavy menstrual bleeding. According to the US NHANES data, the prevalence of iron deficiency anemia among adolescents with the potential to menstruate is as high as 6.3%, with the prevalence of latent iron deficiency, those are persons who are iron deficient without actually developing anemia yet, is even higher at 17% when they use a ferritin cutoff of 15. And when they use a ferritin cutoff of 25, it's even higher, almost 40%. And not surprisingly, the largest contributor to this is heavy menstrual bleeding in a multivariate analysis. So in the adolescent girls, iron deficiency is associated again with poor concentration, fatigue, restless legs, decreased school performance. And when unrecognized, heavy menstrual bleeding can progress to severe anemia, leading to emergent medical care and hospitalization, as we've all seen. It is well described that heavy menstrual bleeding is underreported in women and girls, and often a pathological process is normalized among girls and their families. So mom had heavy menstrual bleeding, sister had heavy menstrual bleeding, auntie have had heavy menstrual bleeding. So they don't really think anything of it. They just think this is normal, and they think the fatigue is normal, and it's just something they have to go through. So it's important for us as physicians to elicit that history and let them know that this is not normal. The heavy menstrual bleeding in itself, as well as the symptoms of anemia, can affect the day-to-day activity and the quality of life of these young women. And so important for us in managing these patients to recognize this, to get a good bleeding history, such as flooding, nighttime soiling, passing of clots larger than the size of a quarter, to aim to objectively quantify the menstrual losses, such as using a pictorial bleeding assessment tool. And just jumping on what Dr. Mackey said, 20 to 30% of these girls will actually have an underlying bleeding disorder, such as von Willebrand disease or a hemophilia carrier state. So that's just a plug to send them my way if you see them. And identifying these patients will allow early intervention before symptoms of anemia can become apparent. So I think we're all kind of familiar with what the typical clinical presentation will look like. So iron deficiency with or without frank anemia is often clinically silent, with signs and symptoms not fully being appreciated until the successful institution of iron therapy. The physical examination should evaluate and characterize tachycardia, the presence of a heart murmur, pallor, the absence of jaundice and hepatosplenomegaly, which is not typical of iron deficiency anemia. Symptoms such as irritability, fatigue, and decreased activity are quite often present in more severely affected children with iron deficiency. Interestingly, the first clinical manifestation in many patients with iron deficiency and anemia is pica, which is an intense craving for a non-food item. Many times these items are not of any nutritional value, and they're often crunchy like dirt, rocks, and cornstarch. And while we don't yet have a complete understanding of why this happens and what the true incidence is, in one clinical trial of young children with nutritional iron deficiency, whose parents were prospectively asked about pica, 49% of the respondents reported that their child did actually have the symptoms. So it's important for us to ask about it. And so in just the figure that you see here is one of the most striking examples of pica, where the corners of the books and the label of the bottle is actually, the bottle for the iron drops is actually ingested by the child, but notably the iron drops, the bottle is still full, so they're not getting their therapy. And so for the laboratory assessment, we must consider that iron deficiency doesn't happen all at once. It becomes abnormal in a stepwise progression, with the serum ferritin, which is the storage form of iron, becoming the first abnormal parameter. And then the hemoglobin is actually the last thing to fall. But if it's not in a setting of acute hemorrhage, the hemoglobin is the last thing to change. And so the presence of clinical risk factors along with a microcytic anemia, meaning a low hemoglobin, a low MCV, and an elevated RDW, red cell distribution width, is consistent with a diagnosis of iron deficiency anemia. Review of the peripheral smear, we all know, will show hyperchromic microcytic red blood cells with a normal lymphocyte visualized there for comparison, and often with an accompanying thrombocytosis. So you see an increased platelet count on the smear, which is highlighted in this photo from the ASH image bank. The thrombocytosis can be quite impressive, close to 1,000, but it is reactive and typically corrects with the correction of the anemia. So there's no need to treat this thrombocytosis in most cases. And in such patients, a course of oral iron therapy that elicits a complete hematologic response confirms the diagnosis. So just to highlight that often one area of debate is what is an acceptable threshold for serum ferritin. So remember, after you actually correct the hemoglobin, you're going to continue iron therapy to replenish your iron stores, usually for about 3 to 4 months. And those iron stores, the marker that we use is the ferritin level. But there's a debate on what is an acceptable ferritin level that defines iron deficiency. Many studies use different thresholds for defining iron deficiency that typically range from a ferritin level of anywhere from 12 to 15 to 40 nanograms per ml. And so this can create some confusion and potentially lead to delays in the diagnosis of iron deficiency. As we mentioned, there is a subgroup of patients who are non-anemic and still have symptomatic iron deficiency. And so these thresholds are important to define. Furthermore, since ferritin is an acute phase reactant, and it is elevated in those with chronic inflammatory processes, undermining its value in such individuals for whom other measures may be more appropriate, such as the transferrin saturation. So there was another NHANES study published in 2021 that examined the relationship of the serum ferritin with 2 independent risk factors of iron deficient erythropoiesis. That's the hemoglobin level and the transferrin saturation. And they did this study in children and non-pregnant women. Of course, any patient with liver disease or elevated markers of inflammation were excluded because these can affect ferritin levels. And so what they found was that at lower serum ferritin concentrations, the median hemoglobin concentration, can you see a pointer? Okay, anyway, at low serum ferritin concentrations, which is if you look to the left side of the graph, the median hemoglobin concentrations decreased. That's on the blue graph, and the transferrin saturations increased. So when you got to lower serum ferritin concentrations, these two measures kind of moved in the opposite direction. And when they used restricted plateau points to determine the onset of iron deficient erythropoiesis, what they found that was that the serum ferritin thresholds identified for both the hemoglobin and the transferrin saturation were not different. So for children, they found that the hemoglobin identified serum ferritin threshold of 19.9 micrograms per liter, and the serum transferrin receptor identified a ferritin threshold of 20. So the plateau point was a little bit higher for non-pregnant females, around 25. But in general, around 20 to 25 level of serum ferritin is where you see iron deficient erythropoiesis happening. And so as a rule of thumb, using this data as a guide, most hematologists would now tend to use a serum ferritin level of at least 20 to 25 to define iron deficiency. And when aiming to replenish iron stores, personally in practice, I try to aim for a serum ferritin level of 50 to say, okay, they can totally stop iron therapy, they're corrected their anemia, they're corrected their iron stores, and we can stop iron. And so once we've identified iron deficiency, how do we fix it? So oral iron supplementation with ferrous sulfate is still the primary approach for treatment of iron deficiency anemia. However, as we know, the medication comes with lots of gastrointestinal side effects, which can decrease compliance and long-term efficacy. And so it is important to understand how best to provide dietary iron supplementation to maximize good absorption and to minimize the unwanted side effects and hence improve patient compliance. This has been heavily studied in the last decade and has helped us to answer some of these questions. Needless to say that in any patient who you identify iron deficiency anemia, the underlying cause has to be identified and corrected. So if not, regardless of any iron therapy that you give, it's likely that they're going to have a suboptimal response or persistence or recurrence of their anemia. And so this may be a good time to review how intestinal iron is absorbed, and I hope this doesn't create any PTSD for anybody, but please just stick with me through this part. Okay, so most of the iron is absorbed in the duodenum or the proximal jejunum because of the acidic nature of the intestinal contents there, and you need to reduce the ferric iron to ferrous iron for it to be absorbed. So the ferrous iron enters the luminal side of the enterocyte, which is that wiggly side on the left. By the iron transporter DMT1 or divalent metal transporter 1. Once the iron gets into the enterocyte, it is transported across the cell to the basolateral surface. So remember, the strongest factor that affects iron absorption is the iron status of the child. And depending on the cellular iron status, iron may become bound to ferritin in the ferritin pool inside the cell, which is then shed if it's not needed, or it is transported to the basolateral side of the cell, efflux through the iron exporter ferroportin, which also is very important, and is subsequently oxidized again, transferred onto the carrier protein transferrin, and then it is either transported to be used by the liver or by the reticular endothelial system to make hemoglobin. So this communication between the iron stores in the liver and the intestinal cells was long not understood, but it has been shown now that there's a polypeptide called hepcidin, which is synthesized in the liver, which is very, very important in this process. So over the last decade, we've come to better understand the crucial role that hepcidin plays, which is circled in orange there, which hepcidin plays in iron regulation. What we now know is that hepcidin blocks the action of ferroportin. So that's the purple thing on the basolateral membrane. And so by hepcidin binding to ferroportin, it causes internalization and degradation, and consequently downregulation of intestinal iron absorption. Hepcidin concentrations are reduced in states of iron deficiency. So when you have iron deficiency, the hepcidin levels go down, and so your body tends to absorb more iron. So it's reduced in iron deficiency, it's reduced in anemia, it's reduced in states of hypoxia, but it's is increased in states of iron sufficiency. So when your body has a lot of iron, you don't need it, so the hepcidin level goes up. And it's also increased in states of infection and inflammation through cytokine stimulation, particularly interleukin-6, which decreases iron availability to pathogens. And so when we think about giving oral iron, we know that iron supplements themselves acutely increase hepcidin levels. But the duration and magnitude of the increase, its dose dependence, and its effects on subsequent iron absorption has not been characterized until recently. This study by Moretti and colleagues investigated whether acute iron-induced increase in hepcidin levels influenced iron absorption of successive daily iron doses or twice daily iron doses. So they looked at healthy females between 18 and 45 years who were iron deficient, meaning they had low plasma ferritin levels less than 20, but they were not anemic. So all of their hemoglobins were greater than 11.7. And they had normal BMIs and normal CRPs. And they conducted 3 separate studies where they were given radiolabeled ferrous sulfate. And what they did was they measured the iron-induced hepcidin levels in the evening or the following day. And they also measured iron incorporation into the red blood cells 14 days after administration. And what they found was that the dose of iron that you give does matter. So for those patients tested in the first, they did 3 separate analyses. So for those patients tested in the first analysis, they found that the fractional absorption of iron decreased when you increase the dose. Even though the absolute absorption increased, it was not a linear progression. So the highest fractional absorption in these women appeared to happen around 60 milligrams of iron given. But as I said, the relationship was not linear. So they administered doses from 40, 80, 60 milligrams, all the way up to 240 milligrams. And what they found that although the dose increased 6-fold, the absolute amount of iron absorbed only increased 3-fold. So example, if they gave 40 milligrams of iron given 24 hours after the first dose, it provided a 6.7 milligram absorption of iron, whereas the second 240 milligram dose only provided an 18.1 milligram of iron absorbed. And as I said, the highest fractional absorbed, the magic number dose appeared to be between 40 and 80 milligrams, so somewhere around 60 milligrams of iron. So this leads you to the question of the need to give higher doses of iron if you're trying to minimize adverse effects such as nausea and constipation, but maximize the absorption that you get. And so one of the other striking things that they found from this study was that the timing of iron administration also mattered. So what they saw was that twice daily administration of 60 milligrams of iron at 10 a.m. in the morning and at 4 p.m. resulted in higher plasma levels of hepcidin at 8 a.m. on the following day compared with once daily administration. So remember, hepcidin is kind of the bad guy with iron absorption, and it impairs iron absorption. So twice daily dosing resulted in higher hepcidin levels the following day. The iron absorption from the afternoon dose, so remember they were getting it at 10 a.m. and 4 p.m. In the afternoon dose, at 4 p.m. dose, the absorption decreased by 26% compared with the first morning dose. And the iron absorption from the following morning, the successive morning dose, decreased by 43% compared to the first dose 24 hours later, and was 20% lower than the afternoon dose given the preceding day. And so twice daily iron supplementation seems to have limited additional effect when compared with daily administration. And so the findings of this study suggest that once daily dosing of oral iron versus twice daily may be better. And there are other similar randomized controlled trials out of Europe in iron deficient females, which had similar findings and showed that at an equal total iron dose compared to consecutive day dosing, they looked at alternate day dosing, and they showed that it didn't result in higher serum ferritin levels, but it reduced iron deficiency at 6 months and triggered fewer gastrointestinal side effects. So some persons, or there's some schools of thought that even think that every other day iron dosing might be better. Um, in infants and young children, unfortunately, a similar study has not yet been performed, which would inform optimal dosing of ferrous sulfate for children. I'm sure you've seen in textbooks and articles historically the recommended dose. I think Harriet Lane still says 3 to 6 milligrams per kilogram per day of elemental iron. For young children, and then 150 to 300 milligrams of elemental iron daily for adolescents and adults. But the supporting data for this is lacking. There was a trial in children called the Besteron trial, which was a double-blind randomized control trial looking at the efficacy of low-dose ferrous sulfate compared to iron polysaccharide complex in treating iron deficiency anemia. So this wasn't a dose response study. They were just trying to compare these two drugs to see which one was better at correcting anemia. But the dose of the ferrous sulfate that the children got was 3 milligrams per kilogram per day of elemental iron. And they got that over a 12-week period. And although it wasn't a dose response study, what they found that was that dose of ferrous sulfate was more effective than the iron polysaccharide complex in increasing hemoglobin concentrations and resolving iron deficiency in young children. And so these findings support the use of ferrous sulfate as a first-line treatment for pediatric nutritional iron deficiency anemia, and a dose of 3 milligrams per kilogram per day is sufficient to correct the serum hemoglobin levels within the 3-month period. And so this data on iron absorption in combination with the clinical trial data support a minimalist treatment regimen of low-dose iron therapy at 3 milligrams per kilogram of elemental iron administered just once daily on an empty stomach or away or like at least 1 to 2 hours away from meals if you're doing it in between meals, and away from teas and coffees for young children, and then 65 milligrams of elemental iron once daily in adolescents with some form of vitamin C. Oral iron is the universally accepted first-line treatment still, and most children have a prompt and favorable response to oral formulations. Of course, this minimalist strategy is just a general recommendation. There may be some cases where you may require higher end of the dose range. Yes, potentially in children with more severe forms of anemia if they're able to tolerate the GI side effects. And as I said, there are some current therapeutic regimens which favor alternate day dosing for correcting anemia, but then you have to deal with the patient potentially forgetting to take the iron or forgetting which day they took the iron. And so that also may lead to poor compliance. So I kind of try to just stick to daily iron dosing, at least upfront. And then once I get to the point where the hemoglobin is corrected and I only need to restore the ferritin levels, and I say, okay, maybe we could do alternate day dosing at this point. And so what's the clinical response we expect? So with consistent use of ferrous sulfate, having corrected the underlying cause for the iron deficiency anemia, what you expect is that you will have a reticulocytosis in 3 to 7 days. Now, I don't generally check a retic count at 3 to 7 days unless I have a patient with very severe anemia and I need to know if they're responding, but you would tend to see that. Most patients, you check a lab a month later, and you would expect the hemoglobin to have responded by then, usually correcting totally by 6 to 8 weeks. And then, as I said, the ferritin will normalize over the next 3 to 6 months. So generally, we end up continuing oral iron therapy for 3 to 4 months to replenish ferritin stores. In general, what we found is that if a patient has not responded to oral iron at 1 month, at the 1 month mark, if they haven't responded like you've expected, whether it is due to non-compliance or the side effects are bad or malabsorption is bad, because compliance is best at the beginning. So if at the 1 month mark they haven't really responded, then they're unlikely to respond if you keep trying oral iron. And so these are patients that you may consider, okay, do I need to initiate IV iron therapy in an ideal world on these patients? And so when has a child failed oral iron therapy? Okay, so let's take a look at a clinical case. So Emily is a 16-year-old female with a history of obesity. She presents with chronic fatigue, frequent headaches, and dizziness over the past 3 to 4 months. She also has occasional shortness of breath on exertion and difficulty concentrating in school. She had an evaluation for bariatric surgery and was found to have iron deficiency anemia during the preoperative lab work. The pediatric surgery team has recommended anemia correction before proceeding with the gastric bypass procedure. So her initial labs are consistent with iron deficiency anemia. She has a microcytic anemia with a low serum ferritin level and an elevated CIBC. And her additional studies such as B12 and folate and thyroid function tests are normal. So she was started on ferrous sulfate, 325 milligrams or 65 milligrams of elemental iron once a day with vitamin C, and advised to take it on an empty stomach. But at follow-up 1 month later, she has persistent fatigue and dizziness. Her symptoms haven't improved, and she has unwanted side effects such as nausea and constipation. So she's not taking the medication anyway. And the repeat labs have shown no improvement, but additionally, you know that she has an elevated CRP of 12. So by definition, Emily has failed oral iron therapy. And while she may have many reasons to have a suboptimal response, such as poor compliance due to adverse effects, maybe she had heavy menstrual bleeding, the cincher here is that she had an elevated CRP level. And in the face of chronic inflammation, as we've discussed, because of hepcidin, you're unlikely to absorb iron well. And so she should be considered for parenteral iron instead. So we now have evidence that obesity can causally contribute to iron deficiency. Essentially, it's an anemia of chronic low-grade systemic inflammation where the adipose tissue leads to the production of increased inflammatory cytokines such as interleukin-6, which we have seen increases hepcidin levels. In one study of South African children, a placebo-controlled trial that investigated whether weight predicts response to oral iron supplementation in iron deficiency, they did find that what they call the BAS, which is the body mass index for age Z-scores, and they analyzed them against the hepcidin level, the hemoglobin, the ferritin levels, transferrin saturation, and CRPs. They found that the BAS score correlated with CRP levels and that the CRP levels correlated with hepcidin levels. They also found that at higher BAS scores, it was a predictor of remaining iron deficient after the period of supplementation. Now, they had a long period of supplementation, 8.5 months, not quite sure why, but higher BAS scores predicted patients staying iron deficient. And I will say that obesity is not an absolute indication for parenteral iron. In most instances, you will try the oral iron first, but if at that 1 month mark, the patient has not had the improvement that you expect, and you know that they have an elevated CRP or ESR, then they are unlikely to respond well with prolonging oral iron treatment, and IV iron should be tried. And these are the other considerations in pediatrics for parenteral iron administration. Now, really, most of our parenteral iron formulations are FDA approved, and most of our experience with parenteral iron is in the case of patients with CKD. But there are some other indications where, you know, this patient is not gonna respond to oral iron, and so trial of IV iron is warranted, whether it's due to intolerance, poor adherence, or inadequate intestinal absorption. Parenteral iron is indicated. So oral iron therapy frequently fails in children who present with gastrointestinal tract disorders such as intestinal failure, inflammatory bowel disease, celiac disease, chronic intestinal bleeding. Other things to consider are iron absorption defects in patients who are on prolonged PPI or H2 receptor blocker use, because that suppresses acid production. And finally, oral iron therapy is inadequate, or when oral iron therapy is inadequate because of a rapid increase in iron levels is required to avoid blood transfusion, such as in a patient with severe perioperative iron deficiency anemia related to surgery with high blood loss. There are some instances as well, and some algorithms exist in some tertiary care institutions where oral iron is administered in the emergency department in the stable pediatric patient with severe iron deficiency in the hope to avoid the need for blood transfusion, but where they still need to rapidly correct hemoglobin levels. And for example, if you have a 4-year-old child who comes in with a hemoglobin of 4, they're stable because their hemoglobin has been dropping for a while. It's a patient who you're not familiar with. You want to start them on oral iron. You don't want to transfuse them for some reason. You don't want to transfuse them, but you're worried that they won't take the oral iron and you can't discharge a patient because they're not going to take the oral iron. In some instances, in some emergency departments, you can give these patients IV iron therapy if you want to ensure that they're getting the iron and rapidly correct their hemoglobin levels. So as I said, in all of the above patients, parenteral iron should be considered. However, the available pediatric experience with intravenous iron products as an alternate to oral iron is limited outside of, as I said, chronic kidney disease, where the patient is mainly hemodialysis dependent and receiving recombinant EPO as well. So understandably, the widespread use is limited still by accessibility and also by cost. And there's still a major concern about the adverse reactions such as life-threatening hypersensitivity that further contribute to the avoidance of parenteral therapy in pediatric practice. Despite the numerous studies in adults with iron deficiency of diverse etiologies, the pediatric studies on parenteral iron use are still limited. Although mostly retrospective and small, though, these studies have documented efficacy and safety with intravenous iron formulations, especially the newer generation of iron formulations. And so to date, there are 3 different generations of parenteral iron, and I'm not going to go into the details of this, just to mention, which differ in terms of their stability, safety, and dosage. The first generation one, high molecular weight iron dextran, should no longer be used if possible because there's an increased risk of anaphylactic reactions with this one. And there are other newer preparations which are available, which are more stable and safer. The second generation one, so that's Venofer or iron sucrose, with which we are most familiar, and ferrous gluconate. These are the second generation ones. They're very efficient preparations, but because you can only administer them in small doses, they require more frequent visits to get those in, and they may only be administered in low doses because of labile iron complexes. And then the newer formulations, the third generation ones, such as the ferric carboxymaltose and fermoxetol, these are the least labile and they offer comparably good safety profiles. They're high complex stability and thus the possibility of rapid application of high doses of iron up to the total cumulative dose. Furthermore, test doses are not required for these preparations, which also simplifies their use. But as you can see, they're also the most costly formulations, which limits availability to everyone. And so I'll stop there in terms of IV iron. So in summary, iron deficiency anemia is the most diffuse anemia in children. Iron deficiency with or without anemia can have long-term neurodevelopmental consequences. Clinical presentations may vary depending upon the severity of the anemia and the underlying cause. Intestinal iron absorption is tightly regulated and decreased in states of infection and inflammation. Oral iron supplementation remains the mainstay of treatment, and there are expanding indications for the use of parenteral iron in pediatrics, and the safety profiles of the IV iron formulations are improving. And that's it. I'm done. Here are my references, and I'll take any questions.
So, wow, we've come to an end. And it's been a long morning, but it's been an educational morning filled with lots of knowledge, lots of excellent speakers, and I'm sure that we were all enriched. So on behalf of the Department of Pediatrics, we thank you for our virtual viewers. And so we actually were up to almost 50 viewers online. And so we thank you all for sitting in and staying with us. And I'm sure we all learned. Yes, the presentations are being recorded, so we've been asked that. And so they will be posted at a later date. And so all of this wealth of knowledge has not gone to waste. So we look forward, to continued success. And so once again, I just want to say thank you to our pediatric social team and also the pediatric department for supporting all of our events. We could not do it without you. And so once again, thank you. I know we're late. Thank you to our wonderful speakers. And we will then close this meeting. Have a good morning. Thanks.